Thank you for inviting me to be here. It's really a pleasure to be talking about autoimmune comorbidities of atopic dermatitis. And before going on, just a disclosure slide. I will be mentioning dupilumab at some point, and I've done some work with Sanofi and Regeneron, and the rest are not relevant. So I want to give an overview about the associations that have been found both epidemiologically, but now we're sort of seeing some more treatment-related, more clinically relevant relationship between atopic dermatitis and various autoimmune comorbidities. So it was really a pleasure to listen to those first two talks as an epidemiologist, really getting into the nitty-gritty of study design and whether associations are real and different types of biases that play a role. And I'm going to be going into some of that here, but mostly I'm going to be focusing clinically. A lot of that is because just epidemiology with regards to atopic dermatitis and these other autoimmune comorbidities is not as well developed. We just don't have nearly as much data, so it's just not as much fun to talk about. But there are some really interesting clinical implications with regards to atopic dermatitis and autoimmune comorbidities. The first question is, of course, from an epidemiologic point of view, is atopic dermatitis associated with autoimmune comorbidities? And thankfully for me, as I was doing a literature review to prepare for this talk, I came across this wonderful study by Jacob's group, which looked at all of these different autoimmune comorbidities and their relationship with atopic dermatitis in their population-based data from Denmark. And so they looked at a wide range of conditions with varying pathogenesis affecting various organ systems, including alopecia areata in the skin, seronegative arthritis, celiac disease, urticaria, Crohn's disease, as well as ulcerative colitis. And the list goes on of all these different conditions that they, thankfully for me, were able to summarize in one paper. And they also did this really nice analysis. They looked at all of these comorbidities individually, but the first analysis they did was this really nice analysis that looked as, is atopic dermatitis associated with one of, or two of, or three or more atopic comorbidities? And I made this forest plot on my own, but the data is from this paper, and you can see that the line that represents the null is way back over here, and there are fairly strong associations seen between atopic dermatitis and a number of autoimmune conditions, whether you have one, two, or three in a dose-response relationship. And all the biases that were discussed earlier, particularly detection bias, which is where, if you have atopic dermatitis and you're seeing a doctor more frequently, they're more likely to diagnose you with alopecia areata, et cetera. All of those could play a role here, but the associations are so strong that it's probably not by chance alone that atopic dermatitis is associated with these various autoimmune comorbidities. And when you look at the individual level, the individual disease level, there were a lot of hits. And Jacob mentioned that you have to be careful because when you use these registries with such large sample sizes and the possibility of detection bias, the likelihood of having a positive hit with some statistical significance is quite high. But it really was remarkable that atopic dermatitis was associated with this wide variety of conditions. The conditions highlighted in orange here are the ones that showed a positive association with atopic dermatitis. And we have to ask why that might be. And so we've heard a lot about why atopic dermatitis might be associated with atopic comorbidities and why atopic dermatitis might be associated with cardiovascular disease, although I remain a skeptic in that regard. So I'll try to get into why there might be an association between atopic dermatitis and various autoimmune comorbidities, although I have to admit it's quite messy. And so when I think about atopic dermatitis pathogenesis, this is really what it boils down to for me, that there are these outside-in and inside-out components. The outside-in being the epidermal barrier disruption, where you have abnormalities in filaggrin or various proteases, and this allows various antigens and irritants in, which leads to inflammation, and it's predominantly a Th2-mediated inflammatory response with a number of important Th2 cytokines, but then these can further suppress epidermal structure protein synthesis and induce proteases. And so really it's this loop, and they loop into one another. And you can start with either one. You can start with epidermal barrier disruption. You can start with inflammation, and they can feed into one another. And again, filaggrin being the most prominent example of the genetic predisposition to barrier dysfunction, this is really thought to play a role in why atopic dermatitis is associated with other atopic comorbidities. And you heard a really nice and fulsome explanation of this earlier, so I won't belabor it, but in fact, I'll just simplify it and say that we have good reasons to understand why atopic dermatitis is associated with food allergy, hay fever, and asthma, largely perhaps because of barrier dysfunction, but other immunologic mechanisms may play a role as well. But why is it associated with these other comorbidities? So, for example, alopecia areata, we don't really think of that as being related to barrier disruption, any epithelial barrier disruption. So how can we tie that in with atopic dermatitis? Well, there was this really nice review article that was published that showed all the different genetic risk variants that have been published in relation to atopic dermatitis. And you can see that, really there are a huge number of genes that have been associated with atopic dermatitis. And what was also nice about this study is that they showed us the number of studies that have replicated those associations. Because, again, you can find a lot of spurious associations when you do these genetic association studies. And you can see that the number of genes with only one association is one study showing an association is quite high, and the numbers get smaller for genes that have been replicated, but still there are a large number of genes that have been associated with atopic dermatitis, and quite a few of them are not related to epidermal barrier. And so just pulling out from that larger slide some of the more immune-mediated or immune-related genes that have been associated with atopic dermatitis in different studies. And they include things that we know about, like Th2-type inflammatory-related genes, such as the interleukin-4 and 13 pathway, but also less specific associations, such as with the JAK-STAT pathway, also association with thymic stromal lymphoprotein, interleukin-31, the MHC, or major histocompatibility locus, interleukin-1, again, showing up here, interleukin-6, which, again, is incredibly nonspecific. And so you can see that it's not just barrier in atopic dermatitis. And so when you're looking at underlying genetic epidemiology and why these conditions might be associated, there certainly are some possibilities. But it's one thing to throw a bunch of genes up on a slide and say, oh, look, maybe there's something here, and do some hand waving. But this really large and well-done epidemiologic study by Yuck and Schmidt's group didn't bear out that hypothesis that it's these inflammatory or immune-mediated genes that are driving these associations. Because in that large study, atopic dermatitis was associated with rheumatoid arthritis, Crohn's disease, and ulcerative colitis, so these major autoimmune comorbidities. But none of it was related to risk alleles for these different conditions. So the risk alleles for inflammatory bowel disease and rheumatoid arthritis were not increased among atopic dermatitis patients. In fact, the authors point out that a number of shared risk alleles in other studies often exert divergent effects on the risk for atopic dermatitis and the other autoimmune disease. So, for example, functional polymorphisms in the interleukin-6 receptor gene are associated with increased atopic dermatitis risk, but decreased rheumatoid arthritis risk. So, what do we make of that? Well, there may be something to a genetic underpinning of atopic dermatitis and potential associations with autoimmune comorbidities, but I think really there's not a lot of strong genetic epidemiology evidence linking these conditions. So, what could it be then? What do these patients have that predisposes them to these autoimmune comorbidities? Perhaps it really is that detection bias. Perhaps another form of bias is creeping in, which hasn't been mentioned yet in all the great epidemiology talks we've heard so far, which is publication bias, and that a lot of these studies publish findings when they show positive results, and if it's a negative study, it gets shelved. We can't really know whether the epidemiologic associations are true or not. I think they've been consistent enough to think that there's something there. But what underlies them? And I think one thing that's important to keep in mind is, especially when you're talking about associations on the level that we're seeing between atopic dermatitis and various autoimmune comorbidities, which is quite small relative to the associations that we see between atopic dermatitis and atopic comorbidities, is that atopic dermatitis is a very diverse disease. This is not just interleukin-4 and 13 mediated disease. There is also a role, a smaller role, and perhaps only in a subset of patients, for things like interleukin 17 and IgE and traditional Th1 type cytokines like interferon gamma. And there has been a lot of really nice work, particularly by Dr. Gutman's group that shows that really atopic dermatitis is this spectrum. It is not one disease. For some patients, and in Dr. Gutman's work, it's in particular the European American phenotype or Caucasian patients who have this more traditional Th2 type inflammatory response that underpins their disease. And in other groups, such as in Asian atopic dermatitis, there is more involvement of cytokines that we traditionally associate with psoriasis, namely Th17. And this may be why we see associations, because atopic dermatitis is not just one entity. There are a number of different ways that someone can manifest as having what we clinically call atopic dermatitis, and perhaps there are some patients whose inflammation predisposes them to an association with autoimmune comorbidities whose pathogenesis is quite different than what we think of atopic dermatitis as. So I'm going to move on now to some individual diseases, and again, a little bit of epidemiology, but moving on to what some of the clinical implications may be. So Jonathan Silverberg and a student of his published this meta-analysis on the association between atopic dermatitis and alopecia areata, which is fairly well described. And I think a lot of dermatologists in clinical practice, myself included, have seen a number of patients with these comorbidities, and they found in a small number of studies a fairly strong association between atopic dermatitis and alopecia areata. And subsequent to that, in a cohort of adult women, we found similar findings for adult onset alopecia areata. And they also examined whether or not atopic dermatitis was specifically associated with more severe alopecia areata in the form of alopecia totalis or alopecia universalis, with less of a convincing association, but still some association seen, because I remember learning when I was a dermatology resident that if you had alopecia areata with comorbid atopic dermatitis, you were more likely to have severe disease and more recalcitrant disease. And while they found something there, and their measure of more severe disease was a very strict definition, there didn't appear to be as much of an association here. And the pathogenesis of alopecia areata is also relatively complicated, with a number of important players involved. So you can imagine that there may be some pathogenic overlap in a patient who has both of these conditions if you look at their systemic immune profile. And in particular, with regards to atopic dermatitis, just drawing your attention to the fact that interleukin 4 and 13 may play a role in the pathogenesis of alopecia areata. And as well, another system that may be targeted for the treatment of alopecia areata are these relatively non-specific agents that target PDE4 and the JAK-STAT pathway. And so if you have a patient with both atopic dermatitis and alopecia areata, you can imagine that you have a number of potential therapeutic options to treat both conditions. And in fact, there have started to be a number of reports that have come out for these targeted agents in treating patients with both conditions. So this is a patient with severe and recalcitrant alopecia areata who also has atopic dermatitis, who was treated with tofacitinib. And you can see that there were improvement in his skin lesions, but also remarkable regrowth of his hair. And in this other patient who had again, severe alopecia areata, not quite universalis because he did have some eyebrow hairs left, treated with dupilumab, improvement of the atopic dermatitis with also really significant hair regrowth, not only on the scalp but on the eyebrows as well. So really some interesting therapeutic potential. I think it's really important to keep in mind that these are just case reports, and while these agents are undergoing further investigation in early phase trials for atopic dermatitis and also alopecia areata, late phase trials and even approval in the case of dupilumab for atopic dermatitis, that we really need to see those late phase trials before we draw any therapeutic conclusions, because we know that like atopic dermatitis, alopecia areata is very unpredictable, and while these case reports are compelling, we need to see more data. In that same systematic review and meta-analysis, Jonathan Silverberg found even fewer studies on the association between atopic dermatitis and vitiligo, but really remarkable effect estimates. I can't remember the last time I saw an odds ratio of 7.8. So there probably is an association there, but again, the potential for detection bias, where someone's seeing a dermatologist for atopic dermatitis, and they also noticed a white patch on their skin and diagnosed them with vitiligo, is certainly there. And when you only have a couple studies in the literature, you have to be skeptical for publication bias as well. But we found similar findings after this meta-analysis in our cohort of adult women. Not quite as strong an effect estimate, but double the risk of adult-onset vitiligo in adult women with atopic dermatitis. They also tried to look at whether there was an association between atopic dermatitis and earlier onset vitiligo. And while they found a statistically significant association, you can see that it was really heterogeneous, with one of only 3 studies showing no effect, and these 2 studies dragging the effect estimate over. So unclear if there's a specific association between atopic dermatitis and early onset vitiligo. And vitiligo, when you look at this cartoon for vitiligo pathogenesis, you can see that, again, JAK inhibitors are a potential therapeutic target when thinking about how vitiligo comes about and how we might use anti-inflammatory treatments to treat it. So again, some case reports showing repigmentation of vitiligo with JAK inhibitors, and we know that these agents are undergoing studies in clinical trials as well. And so again, JAK inhibition is a potential mechanism to treat a patient who comes in and has both atopic dermatitis and vitiligo. Moving away now from the skin and associations between atopic dermatitis and rheumatoid arthritis, and I have to say that unlike with alopecia areata and vitiligo, where I can think of a number of patients of mine who have both conditions, I can't actually think of a patient of mine who has rheumatoid arthritis and atopic dermatitis. So again, I'm skeptical of this association, although it was significant across these 3 different epidemiologic studies that I found that examine the association in these different countries. But nevertheless, at least in these published epidemiologic studies, there appears to be an association there. And when you think about the pathogenesis, there are a number of potential links between rheumatoid arthritis and atopic dermatitis, mostly because the pathogenesis of both is so complex and heterogeneous. But of course, Th17 and Th1 are involved, and we know that those can be involved, particularly in certain subsets of atopic dermatitis patients. And so there is some potential pathogenic overlap, although it's not overly convincing and it's fairly nonspecific. And I'll just point out that in these treatment guidelines for rheumatoid arthritis, JAK inhibitors are now listed as a potential second-line treatment for patients who failed traditional DMARD therapy and who have moderate or high disease activity. They can then move on to second-line therapy, which could include tofacitinib with or without methotrexate. And baricitinib also, since the publication of those guidelines, has come out as a potential treatment for refractory rheumatoid arthritis. And we know in this early phase clinical trial for baricitinib and atopic dermatitis, it appears to work as well. And so while we await further data, it appears that this JAK-STAT pathway is something that you might go to in a patient who has comorbid rheumatoid arthritis and atopic dermatitis. Inflammatory bowel disease, similar associations found between inflammatory bowel disease and atopic dermatitis compared to those with rheumatoid arthritis, with some stronger associations, particularly in the Denmark study, but largely effect estimates on the order of about 1.5 times the risk of developing one of these conditions if you have atopic dermatitis. Again, skeptical as to whether this is a true association or not, but nevertheless, there are potential therapeutic implications, and I can think of a number of patients of mine who do have inflammatory bowel disease and atopic dermatitis, and that may be because they both occur in younger patient populations, and so you're more likely to see them together. But when you're thinking about targeted therapy for inflammatory bowel disease, T and F inhibitors clearly do not work for atopic dermatitis, and in fact, they can cause these dermatitic reactions that are paradoxical. They also treat inflammatory bowel disease with alpha-4 beta-7 integrin blockers, and this has not been examined as a potential treatment for atopic dermatitis. And ustekinumab, which is also approved for use in inflammatory bowel disease, has been discouraging in the trials that have been published to date for atopic dermatitis. But again, JAK inhibitors are rearing their head and saying that they may be an option to treat patients who have both of these conditions simultaneously, as tofacitinib has been described as a treatment for inflammatory bowel disease and can work for atopic dermatitis as well, although it remains under study. There are some therapies that have been approved for other conditions that are comorbid with atopic dermatitis, but that have been disappointing for atopic dermatitis. I mentioned already ustekinumab as being one of them, but omalizumab as well as apremilast have been disappointing for the treatment of atopic dermatitis. And so even when there are pathways that are shared between two conditions, atopic dermatitis and another autoimmune comorbidity, the targeted treatments don't always work. So to summarize, atopic dermatitis is associated with many autoimmune diseases in epidemiologic studies, but the biases that were discussed in the previous talks apply here, and publication bias, I think, may play a role as well, particularly here because there are so few studies that have been published. And the role of shared genetic and inflammatory mechanisms is unclear. The pathogenesis of these diseases is very different. When one gene pops up as potentially being involved with atopic dermatitis and another condition, the mechanisms are often divergent. But the inflammation in atopic dermatitis is heterogeneous, and so for subsets of patients with a certain inflammatory or immunologic signature, that may explain the associations. And for atopic dermatitis patients with autoimmune comorbidities, there are clear clinical implications because while we're not quite there yet in terms of precision medicine picking the right drug for the right patient based on their genes or their inflammatory profile and so forth, when patients have comorbidities, we can actually use precision medicine, or at least we will be able to in the coming years as more and more agents are studied and approved for atopic dermatitis.